Dear colleagues, dear doctors, ladies and gentlemen, Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, we would like to welcome you here in this scientific event where we are going to be all of us together to highlight an important aspect of one of our challenges that we encounter in our day-to-day practice. But before we start, let me just highlight an important point that all of us, we realize and we know that non-communicable disease in a rise, not only globally, but especially with a special focus in the Kingdom of Saudi Arabia and in the nearby Gulf countries. Despite all the efforts that we have paid in terms of allocating all the resources or even having smart molecules following the guidelines, but in spite of this, patients with diabetes, they are not achieving the target goal of A1C, and most of the time they are subjected to the complication of diabetes in terms of retinopathy, nephropathy, or even diabetic peripheral neuropathy. And in fact, we have realized nowadays with a new change in our healthcare system that we have to invest heavily in the early detections of the disease and specific protections of certain populations at risk. And that's why we are promoting the health promotion to be one of the tools to promote the health and to relieve our patient with diabetes from the deadly complications of the disease. And of course, as we go through our practice in the past couple of years, we have witnessed that the scope of primary care physicians has increased dramatically, and the primary care physicians become responsible for treating the disease and managing patients in total. And also he's becoming responsible of the bad outcome that might happen to our patients, that they are not taking care according to the desirable clinical pathways and the guidelines that is recommended to take the patient all the way away from these complications. So the involvement of primary healthcare in the complications is very important. And I remember one of the statements which has been said by the American Academy of Family Physicians. They said, if a patient with acute coronary syndromes came to the emergency department and went to cath lab, he will be counted as a failure of the primary care physicians who did not do his job to manage the patient early stage and detect these kind of complications and safeguard the health of patients. So today, ladies and gentlemen, we are going to shed a light on our patient with diabetes who is subjected to many complications, with a special focus on one of the very important complications, which is diabetic nephropathies, which is one of the very common problems that we encounter in our day-to-day practice, and it shoulder our healthcare system with a lot of consequences in terms of financial burden, and it impaired the quality of life of our patients who are patients with diabetes and chronic kidney disease. So today, without any further ado, we would like to learn more about chronic kidney disease in the early stage, how to screen, how to diagnose, how to treat, and when to refer patients, and what are the novel molecules that has been available for us as a primary care physician to use and to manage patients. So a long time ago, we used to refer patient immediately to the nephrologist for chronic kidney disease, but now we are in the era of demonstrating full competency, full responsibility, and full commitment towards our patients with diabetes and chronic kidney disease. So still, we can manage a good number of patients with certain stage, and this is what we are going to learn from Dr. Abdul Hamid Hassan, who is a consultant family medicine. He's a senior consultant family medicine, and he has been practiced for many years, and he's a well-known figure in medical education, especially for primary care and family physicians. And he's a senior trainer for the Saudi board in family medicine. He has a very big list of commitment to our society in terms of being a physician and being an educator and a researcher. So Dr. Abdul Hamid today, he's going to talk about Ferinode in the chronic kidney disease with type 2 diabetes, connecting the evidence to the clinical practice. So I would like to leave the floor for you, Dr. Abdul Hamid, and I would like to remind our colleagues who are attending today, they are almost approaching the 1,000. So please put your question in the Q&A box, so I'll be able to collect those questions, which is relevant to the talk, and deliver it to Dr. Abdul Hamid. So 30 minutes or maybe 35 minutes will be delivered to us by Dr. Hamid, and then we will have the Q&A session. I would like to remind you that this scientific event is under the umbrella of the Saudi Society for Family and Community Medicine with partnership with Bayer. So I would like to thank both parties for giving us this wonderful opportunity. And I would like to remind you, ladies and gentlemen, so this is an accredited scientific session with 2 hours from the Saudi Commission for Health Specialty for continuous medical indications. So I would like to thank you, Dr. Hamid, for accepting the invitation today and being part of this wonderful evening and for this wonderful, successful event, inshallah. So the floor is yours, Dr. Hamid.
Thank you, Dr. Ashraf. Assalamu alaikum wa rahmatullahi wa barakatuh.
Salam.
Bismillah ar-Rahman ar-Rahim. Walhamdulillah Rabbil Alameen. Wassalatu wassalamu ala Sayyidil Mursaleen. It is my pleasure to be with you. The screen is shown now.
Yes, sir. Yes, Dr. Hamid. Yes, we can see it.
As Dr. Ashraf mentioned, we are going to talk about finerenone, its place in chronic kidney disease in patients with type 2 diabetes, connecting evidence to clinical practice. As usual, I prefer to put my introduction in the form of review of the literature, what's recent and what we are going to hear in the future. Recently, we got from the KDIGO, the 2024 chronic kidney disease guidelines, very, very elaborative guidelines covering every aspect of chronic kidney disease and how to manage very nicely put it. And they said, when you identify patient at risk for chronic kidney disease, as our patient, all patients with type 2 diabetes, you need to screen with GFR and albumin creatine ratio. It is a must. Number one, estimated GFR creatinine. Unfortunately, many places there is no cystatin C GFR, so we'll follow the creatinine GFR and albumin creatinine ratio. I'm going to repeat it many times. It is not urine analysis. It is not urine dipstick. It is urinary albumin creatinine ratio, and if the creatinine less than 60 or the albumin creatinine ratio is more than 30 milligram per gram, you first go for, you need to repeat. If 2 out of 3 tests are positive, you will diagnose the patient with chronic kidney disease. And this is very important for family physician. This is our role in this most important point. Then we'll go for management, as Dr. Ashraf said, then we'll go for when to refer. But this is a must. As you can see, you may need to measure GFR for cystatin C if it is available. It is available in our hospital, but not available in many other areas. Once we diagnose chronic kidney disease with type 2 diabetes, lifestyle modification number one, then first line, at the same moment, you need to start SGLT2 inhibitor and RAS blocker. And maximize the dose of RAS blocker, ARBs or AC inhibitors, to the maximum tolerated level. Once you achieve this, you will go directly to non-steroidal mineralocorticoid receptor antagonist finerenone. This is the guidelines with no exception, no excuse. We will talk about how to prescribe finerenone in details at the end, but this is the guidelines, 2024. Screen all at-risk patients. If it is confirmed chronic kidney disease, 2 out of 3 positive tests, you start lifestyle and the 2 medications at the same moment. If not, the patient on them, because most patients with diabetes, they have hypertension on a RAS blocker, they have diabetes, mostly they are in SGLT2, but if not, you start them. I remember in 2020, the KDIGO said you need to add SGLT2 inhibitor, if the A1C is not to target, add it. If A1C is at target, remove one of the anti-diabetic medication and add SGLT2. So SGLT2 and RAS blockers are a must first line from day one, And once you achieve maximum tolerated statin RAS blocker, you add finerenone as second line. And the maximum tolerated RAS blocker dose is every 4 weeks sequential. Don't wait 3 months, 3 months. No, 1 month. If not at the target and tolerated, increase the dose. After 1 month, evaluate the patient and increase. Keep on increasing the dose of RAS blocker till you reach the maximum tolerated dose. Then at once you will start finerenone. This paper talking about finerenone in heart failure. This is a study not yet getting an approval for indication, but it is to show you how finerenone will be beneficial because it is treating fibrosis and cirrhosis and sclerosis. And cardiac muscle also suffers from fibrosis, and that's why it is useful in patients with preserved ejection fraction and mildly reduced ejection fraction. This is another paper talking about the relationship between chronic kidney disease and the cardiovascular disease, because as you know, most patients with chronic kidney disease or most patients with diabetes and chronic kidney disease will die from cardiovascular disease. So we consider chronic kidney disease as a cardiovascular risk factor, and this paper talking about the connection and relationship between chronic kidney disease and the cardiovascular disease risk assessment. The editorial following this paper saying that kidney and the heart alone is minimal risk, but together it is very bad outcome. So we need to tackle these problems as early as possible, preventing the progression of chronic kidney disease by early detection and rapid intervention. That's why the American Heart Association in November last year, they proposed a new syndrome called cardiovascular kidney metabolic syndrome, talking about starting with adiposity, with the increased adiposity or dysfunction adipose tissue, progressing to inflammation, oxidative stress, insulin resistant, and vascular dysfunction, and affecting the cardiovascular hypertension, dyslipidemia, the kidney problem, and the cardiac problems. All started with the cardiovascular kidney metabolic syndrome. They assigned 5 stages for the syndrome. They said stage 1, 2, 3, 4, and 4. And they said for the management of all these syndrome is, as you know, lifestyle modification, pharmacology, and surgery. In pharmacology, they mentioned many drugs we used in all the components of the syndrome if we are treating hypertension, dyslipidemia, diabetes, chronic kidney disease, and they mentioned by name finerenone. This is for stage 1, 2, and 3 of the syndrome. For stage 2 specifically, as you can see, for chronic kidney disease component, they said RAS blocker, SGLT2, and finerenone. Even for stage 4 of the metabolic syndrome, they said in chronic kidney disease component, you need to use these 3 pillars: the RAS blocker, the SGLT2, and the finerenone. So it is a must now to be used for such patient to prevent the progression of the problem. 4 weeks later, they proposed a calculator, new calculator for the risk assessment, and they included the chronic kidney disease markers in the calculator. The PREVENT model based on a study of 6.6 million participants. It includes social deprivation index, and it includes the risk for 10 years and 30 years. It will measure the risk for cardiovascular disease, atherosclerotic cardiovascular disease, and heart failure, the probability for your patient to develop heart failure. And it included patients from the age of 30 to 79. And in the equation, you will put the social factor, the body mass index, the GFR, the urinary albumin creatinine ratio level, and the A1C. That's why it is to calculate the cardiovascular kidney metabolic risk for your patient. This is an example of the calculator. you enter the sex, the age, the total cholesterol, the HDL, the systolic blood pressure, the body mass index, the GFR, diabetes or no, smoker or no, on antihypertensive medication or no, on lipid lowering medication or no. Then you will enter the urinary albumin creatinine ratio, the A1C, and you can calculate the risk for cardiovascular disease or the risk for atherosclerotic cardiovascular disease or the risk for heart failure. Very, very useful calculator. You can Google it, prevent calculator, and you download it in your desktop, and you can manage your patient according to this. This calculator was released in December 12 last year. Just 2 months later, in up to date, they mention about it. And they said the prevent calculator is a valuable tool for individualizing risk assessment. So it is very useful. Stop using the atherosclerotic cardiovascular disease risk scoring. Stop using the score 2 and for the European, and it is better to use the prevent calculator for the cardiovascular, kidney, metabolic risk for the patient. Now let us talk about, after this introduction, about our lecture today. We know that chronic kidney disease will add a burden to patients with type 2 diabetes, comparing patient with diabetes alone or diabetes with chronic kidney disease. If the patient has diabetes and chronic kidney disease, there is a twofold increased risk of myocardial infarction and five-fold increased risk of heart failure and 3 to 6 fold risk of heart failure hospitalization and 3-fold increase of cardiovascular death. And with type 2 diabetes, there is a higher risk for ER visit, 2 to more percent increase, and higher rate of inpatient admission by 400% increase, and higher rate of receiving dialysis for 4 to 40 more times. Why I insisted at the beginning urinary albumin creatinine ratio? Because urinary albumin creatinine ratio will appear very early before the deterioration of the GFR. So it will take few years before the reduction of GFR below 60, while there is urinary albumin creatinine ratio more than 30 milligram per gram very early before that. That's why the screening for chronic kidney disease should be serum creatinine, GFR creatinine with urinary albumin creatinine ratio. This is very, very important to screen for that. And all guidelines said the same. GFR for creatinine, urinary albumin creatinine ratio, and if it is normal, repeated every year. And the recommended using GFR and urinary albumin creatinine ratio to probably identify and stage and monitor patient with chronic kidney disease and support routine GFR and urinary albumin creatinine ratio for patient with type 2 diabetes. As you can see, the higher the urinary albumin creatinine ratio, the higher the percent of cardiovascular event. And as you can see, from early on, there is a diversion of the curve with patient increasing the urinary albumin creatinine ratio. And also for kidney composite outcome, the higher the urinary albumin creatinine ratio, the higher the possibility of end-stage kidney disease or doubling the reduction of doubling the increase of serum creatinine or increase cardiovascular mortality. So it is very sensitive, very important marker for chronic kidney disease. So the American Diabetes Association approved using urine dipstick for to calculate urinary albumin creatinine ratio, and we need 2 positive tests out of total 3 tests within 3 to 6 months. So every month, every second month, you repeat the screening. And if we have 2 out of 3 positive tests, we confirm the diagnosis of chronic kidney disease. The 24 hours is no more needed, and it is problematic. So they went for the spot urinary albumin creatinine ratio measurement. We need to take care that exercise and fever, congestive heart failure, hyperglycemia, menstruation, and marked hypertension may elevate urinary albumin creatinine ratio in your patient. The ADA 2024 this year guidelines, we should refer patient to nephrologist when the GFR reduced less than 30 or progressive reduction. This is the heat map from KDIGO, and it is in consensus with the American Diabetes Association consensus statements. They classify the chronic kidney disease by 2 stages depending on the GFR and stage depending on the albuminuria. GFR from G1 to G5 according to the reduction in GFR, and albuminuria from A1 to A3 if the urinary albumin creatinine ratio less than 30 milligram per gram, or from 30 to 300 or more than 300. And we stage the patient, for example, G3B and A2, for example. This is the classification recognized by nephrologists, by the diabetologists, by family physician. This is the way to classify. Then you need to screen if GFR more than 60 and urinary albumin creatinine ratio less than 30 annually, or even more frequent if there's any other risk factors. And if it is starting from G3A and A2, or G3A and A1, or G2 and A2, you need to start to treatment. As a family physician, you are advised to start a treatment and continue treatment follow-up. Then you may refer if the patient is G4, for example, with A1, or G3B with A2, or G3A with A3. This patient need joint management between you as family physician and the nephrologist. And finerenone, as I told you, is working on the heart and the kidney. It is a highly selective non-steroidal mineralocorticoid receptor antagonist that will block the mineralocorticoid receptor activation, overactivation, and will reduce the fibrosis and the sclerosis in the kidney and in the heart. Till now, we have indication to be used in the chronic kidney disease only. For the heart failure, there's no recommendation to use it till now, but there is a promise that in the future it might be also very beneficial. The studies supporting the use of finerenone in chronic kidney disease it will studies heavily in a total of more than 13,000 patients. It was first 2 double-blind randomized controlled trials, each one almost 6,000 patients. The first is Fidelio DKD and Figaro DKD. The results were combined with a pre-specified pooled analysis in the Fidelity, including 13,000 patients. The patient in total was randomized to 6,500 patients to receive finerenone, whether 10 or 20 milligram once daily, or placebo. And the follow-up was almost 3 years. The inclusion criteria for the finerenone study in diabetic kidney disease, adult above the age of 18, GFR from 25 to 90, and urine albumin creatinine ratio from 30 to 300, or GFR less more than 25, but urine albumin creatinine ratio more than 300. So a wide scope of patients we meet in our clinic will be suitable for receiving finerenone. The serum potassium should be was less than 4.8, and the maximum tolerated dose of RAS blockers was 4 weeks. As I told you, you need to escalate the dose of RAS blocker every 4 weeks till you reach the maximum tolerated dose. Then, after that, you will prescribe finerenone for your patient. It is not suitable to use it in patients with heart failure with reduced ejection fraction, NIHA class 2 and 4, or uncontrolled hypertension, A1C more than 12%, history of non-diabetic kidney disease till now. We don't know what the future will have for this finerenone for patients with non-diabetic chronic kidney disease. But till now, it is indicated for diabetic kidney disease. It not included patients with a stroke, transient ischemic attack, acute coronary syndrome, or hospitalization of heart failure, or urinary albumin creatinine ratio more than 5,000. The result of the pre-specified fidelity study of 13,000 patients, it showed a 14% reduction of reducing the risk of cardiovascular morbidity and mortality, and a 22% reduction in the risk of first heart failure hospitalization. For the kidney, there is a 23% reduction of the chronic kidney disease progression, and 20% reduction for risk to end-stage kidney disease. And there is a total of 32% reduction of increasing urinary albumin creatinine ratio for the whole study. The adverse events were comparable to the placebo among the two randomized controlled trials and the pre-specified pooled data in fidelity. There is any adverse event was almost similar to the placebo. Acute kidney injury almost similar, even less, but no statistically significant difference. Systolic blood pressure is minimally reduced, so it will not induce serious hypotension. Like other mineralocorticoid receptor antagonists, gynecomastia is very minimal and no change in A1C. For hyperkalemia, very minimal. The maximum difference in the serum potassium between finerenone and placebo was only 0.19 millimole per liter after 4 months of the drug, and there is no zero cases of hyperkalemia leading to mortality. We need to take care that some patients are at higher risk to develop hyperkalemia on finerenone. Those are patients with high baseline potassium, patients with more lower GFR, patients with higher urinary albumin creatinine ratio, and patients on beta blockers. We know that once we start finerenone, there is a primary reduction in the GFR, but this is not serious, not maintained, and it will assure you that the finerenone is working. Then over time, the reduction will be minimal compared with the patient on placebo with progressive reduction of the GFR for those who didn't benefit from finerenone. So this decrease appeared to be reversible, and the efficacy and safety profile of finerenone will not modify. So don't worry for the early minimal reduction of GFR after starting finerenone. Similar dip of GFR have been observed in SGLT2 inhibitor, yes, and were not associated with progressive loss of kidney function or acute kidney injury. So finerenone will improve heart and kidney outcome. As you can see, for the kidney, there is helpful across stages of chronic kidney disease, including patient with early chronic kidney disease, as well as stage 4. I told you the inclusion criteria cover a lot of patients we are seeing in our clinic every day. It is beneficial regardless of the baseline blood pressure and irrespective of GLP-1 receptor agonist. By the way, GLP-1 is recommended after SGLT2 if you need to add any medication for diabetic kidney disease. GLP-1 could be used also, but the primary pillars, SGLT2, RAS blocker, and finerenone. Then there is an option for GLP-1. Also, the benefit is achieved regardless of the baseline A1C, irrespective of atherosclerotic cardiovascular disease history, and irrespective of SGLT2 inhibitor. So it is very important to use SGLT2 inhibitor, but not a prerequisite to use finerenone. The only prerequisite to use finerenone is a RAS blocker. This is how to use finerenone. So it is used for type 2 diabetes with chronic kidney disease if serum potassium less than 5 and GFR more than 25. The standard dose is 20 milligram daily. But according to the GFR, you will select if the GFR less than 60, you will use at the beginning 10 milligram daily. If the GFR is more than 60, you will use the 20 milligram once daily. Then you need to adjust the dose. You need to test GFR and the serum potassium after 4 weeks. And then you need to adjust the dose accordingly. How to adjust the dose? If the serum potassium after 4 weeks is less than 4.8, you keep the patient on 20 to keep on 20, and patient on 10, you increase his dose to 10 milligram once daily. If the serum potassium is after 4 weeks from starting finerenone, I am repeating, is from 4.8 to 5.5, you keep the same. The patient on 10, and the patient on 20, keep him on 20. If the serum potassium more than 5.5, you need to withhold the finerenone for a few weeks and then test potassium after 4 weeks. You need to measure serum potassium and GFR after 4 weeks from starting the finerenone, as I said, and readjust the dose, whether to increase to 20 or keep it as it is. You need to test serum potassium and GFR 4 weeks after restarting the treatment, and you need to test for serum potassium and GFR 4 weeks after increasing the dose from 10 to the standard dose for finerenone, which is 20 milligram once daily. Then we need to monitor serum potassium and GFR at least 3 to 4 times every year. I would like to remind you that patient at higher risk for hyperkalemia, patient with high baseline potassium, patient with low GFR, high urinary albumin creatinine ratio, and patient on beta blocker. These patients you need to focus more. You might need to evaluate serum potassium GFR more frequent than other patients without all these risk factors. So all guidelines said the 3 pillars for diabetes with chronic kidney disease: RAS blocker, then non-steroidal mineralocorticoid receptor antagonist, finerenone. Then would you like you had been advised to use SGLT2, but it is not a prerequisite to start finerenone. This is the prerequisite for the starting of finerenone. There are new 3 distinctly different classes of drugs with a strong evidence base and the level A guidelines recommendation: RAS blocker, finerenone, and SGLT2 inhibitors. So the American Association of Clinical Endocrinology 2022, they mentioned finerenone by name, and the inclusion criteria in the studies are here to use it with GFR more than 25 and urinary albumin creatinine ratio more than 30 milligram per gram. The KDIGO 2022 and the 2024, as I showed you in the recent update, again recommending finerenone by name. The ADA in 2023 and the 2024, they put finerenone recommended for patients with diabetes and chronic kidney disease and European Society of Hypertension are talking about finerenone also in chronic kidney disease. So all guidelines, whether endocrinology, nephrology, diabetes, hypertension, and at the beginning, I mentioned the American Heart Association cardiovascular kidney metabolic syndrome. They mentioned finerenone in stage 2 and stage 4. Once there is chronic kidney disease, finerenone was mentioned with SGLT2 and RAS blocker. So it is standard of care now to use finerenone for such patient, as Dr. Ashraf mentioned, to prevent the progression of the pandemic we are facing of chronic kidney disease and the cardiovascular kidney metabolic syndrome. What about real world evidence? We have two studies. I will mention one only for sake of time. The Fountain database. It is describing the patient characteristics and to assess the earliest safety and effectiveness of finerenone used in chronic kidney disease with type 2 diabetes in routine clinical practice. The data source from United States, the study period from 2021 to the August 2023, patient adult with chronic kidney disease and type 2 diabetes who had been initiated on finerenone, and the design is observation retrospective longitudinal single arm cohort study. The key outcome, the baseline characteristics, the incidence of hyperkalemia, and the change in urinary albumin creatinine ratio over time from 2021 to 2023. Females with 44%. It included 16,000 patients. The mean age is 70 from 6 to 80. The majority were white. The patient included for the first year with only 1,000. In the second year, 8,000 patients. In the third year, 7,000 patients. You see how the increase in including patients to receiving the benefit of finerenone once they diagnose chronic kidney disease in type 2 diabetes. Hypertension was predominantly present in almost 100% of the patient, and this to assure you that most of the patient will be already in RAS blocker, so you are not going to waste time to escalate the dose once the patient on the maximum tolerated RAS blocker for hypertension. You can start finerenone at once. The many patients, 40% were with coronary artery disease, 25% with heart failure. The stages of chronic disease, the majority were stage 3, and 13% were either stage 2 and stage 4. The albuminuria category, as I told you, we stage chronic kidney disease according to the GFR and according to the albuminuria level. The majority were in albuminuria A2 and A3. Almost 80% of the patients were in these two categories. Then, finerenone was initiated in combination with other drugs. 50% of the patients were initiated on patient using RAS blocker, and 40% were using SGLT2 inhibitors. 25% of patients were using GLP-1, and 30% were on insulin. The difference in patients using 10 milligram or 20 milligram, as I said at the beginning, if GFR is less than 60, we'll start at the beginning with 10 milligram. If the GFR more than 60, we will start with 20. And after 4 weeks, if the potassium is normal, we will upgrade patients on 10 to 20. So patient at the beginning of the recruitment of the study, 85% of the patients were on 10 milligram and only 15% were on 20 milligram. At the end of the study, the patient upgraded to the 20 milligram increased from 15 to 30%. So doubling the number of patients increased to 20 milligram. I expected if we follow the guidelines, probably more patients will need to be up titrated to 20 milligram. So don't be hesitant. You should have the courage when the potassium is normal after 4 weeks. You don't be hesitant to escalate the patient from 10 milligram to 20 milligram. And 70% of the patients in this database were kept on the same, maintained on the same dose of 10 milligram. So the incidence rate of hyperkalemia was 1.96 among 16,000 patients. Out of 16,000 patients, only 200 patients developed hyperkalemia. And for hyperkalemia associated with hospitalization, with only 7 patients out of the 17,000 patients. So it is not too much. And all what you need to do is to measure serum potassium frequently, whether the patient at high risk for hyperkalemia or low risk for hyperkalemia, and follow the recommendation for using the finerenone with hyperkalemia. And reduction of urinary albumin creatinine ratio was very significant over 1 year. At 4 months, the reduction was 40% reduction from the baseline, and it was maintained. There is no deterioration of the kidney function after 1 year from starting finerenone. You achieve a good benefit by reducing the urinary albumin creatinine ratio by 40%, and you maintain this benefit for 1 year in this database. To conclude my presentation, few slides to sum up what had been mentioned. This is a slide from one of our colleagues, expert in nephrology, who, as a reminder, he said the 5. For serum potassium, you need to remember, if the serum potassium less than 5, you can initiate finerenone. And you need to withhold the finerenone if the potassium is 5.5. So for potassium, remember 5 and 5.5. For the GFR, remember 25. If the GFR more than 25, you can initiate finerenone. For the protection and the benefit your patient is going to gain from your initiative to start him in finerenone, you can reduce the risk of end-stage kidney disease by 20%, and you can reduce the risk of heart failure hospitalization by 20%. So the rule of 5 could be used as a reminder for simplifying the use of finerenone. In summary, there is a high unmet need for heart and kidney risk in patients with chronic kidney disease and type 2 diabetes. Albuminuria is very easy, but please measure urinary albumin creatinine ratio. Finerenone is a highly selective non-steroidal mineralocorticoid receptor antagonist for chronic kidney disease with diabetes. Finerenone shows cardiovascular and kidney protection, and finerenone has demonstrated good safety outcome and an easy-to-use profile. Ongoing and planned study programs will generate data more about finerenone. This is one patient I have in my clinic. He is 57 years old. He has a cardiovascular kidney metabolic syndrome, pre-obesity, type 2 diabetes, chronic kidney disease, hypertension, dyslipidemia, and prostatic hyperplasia. his albumin creatine ratio is 185 and serum potassium 4.7 on valsartan empagliflozin. And in May 2023, his albumin creatine ratio increased to 224. I started him finerenone 20 milligram because GFR more than 60. After 2 months, his GFR improved to 85, albumin creatine ratio reduced to 82, serum potassium still in the normal. I maintained him on finerenone 20 with RAS blocker and the SGLT2 inhibitor. In August 2023, the albumin creatine ratio is 75, serum potassium 4.2 on the same medication, maintained on the same medication. And in October last year, serum potassium 4.1 on the same medication. So we improve at least we withheld the progression of the deterioration. Not only that, but will improve the markers of the chronic kidney disease and maintained him on the 3 pillars: RAS blocker, finerenone, and SGLT2 inhibitor. Thank you.
Thank you so much, Dr. Abdulhamid. And yes, thank you, Dr. Abdulhamid, very much, for the wonderful presentation, which has been ended by a wonderful case that touched the reality of your practice. And it was very interesting to know that this patient has been benefited of finerenone across the spectrum of the disease from May 2023 till February 2024 with a progressive improvement of the eGFR. So this is a clear message to all the primary care physician to identify those patients at risk in the early stage and then manage them with the finerenone to get this kind of results. So now we'll open the questions for questions. In fact, I have one of the questions, Dr. Abdulhamid, which was striking me personally. You mentioned about the Prevent calculator. Prevent calculator now, I think this is the tool that we have to use now onward, especially the cardiovascular risk is measured between 10 and 30 years. Long time ago, we usually calculate the risk for cardiovascular just for 5-10 years. So what is the rationale to go all the way to 30 years? Are we forecasting the cardiovascular to that extent? And I heard from you personally that still it's not only in adults, but even in pregnant ladies in the embryo stage, still we can calculate the risk of the cardiovascular. So if you just can shed a light on this, please.
Thank you, Dr. Asher. Very excellent question. You said we are in a pandemic of the cardiovascular kidney metabolic syndrome.
Yes.
And it is occurring very early in life. You have young adult of 30 years, 35 years with the markers of the syndrome, whether hypertension or dyslipidemia or pre-diabetes.
Mm-hmm.
Those patients, الأعمار بيد الله, they will not die within 10 years. But if we left them untreated, they for sure will die without treatment within the coming 30 years. That's why the Prevent calculator starting calculating this from the age of 30. For those patients, if you calculate only the 10 years, the risk will be very low and you will be reluctant to treat them. But if you calculate the risk for them by the age of 60 or 55, you will realize how high the risk and you will need to treat them aggressively as early as possible. That's why we used to say the earlier the better. Don't wait the patient 32, 35, don't treat his hypertension. Don't treat his pre-diabetes. He is young and the risk is 10 years, very low. But if you calculate the lifetime risk or the 30-year risk, you will realize that the risk is very high and you should initiate treatment from that time. Don't wait till the age of 50 or 55 to start the treatment.
Okay, thank you so much, Dr. Abdulhamid. One of the things that is concerning the primary care physician is the use of finerenone that reduced the eGFR in the first couple of months. So how about if this finerenone was combined with SGLT2, which also reduced further the EGFR. Is there any kind of concern in combining these two medications and having a lower GFR in the first couple of months?
No, we need to follow, because we said we need to follow the GFR and the serum potassium and the albumin creatinine ratio.
Yes.
So the study showed that this initial drop is only transient and quickly it corrects itself. Similarly to SGLT2, so no problem for this, and you need to monitor the patient and follow, and most probably it will be corrected itself over time.
Right. Thank you. For those patients with congestive heart failure, already they are on Lasix and spironolactone to prevent hypokalemia. So adding finerenone for those patients with congestive heart failure and chronic kidney disease. So will this increase the risk of hyperkalemia? Having the spironolactone with finerenone?
I think it is not till now recommended because in the exclusion criteria of the
Excluded.
study, they were excluded. But the study I showed in the recent update, it could be beneficial, but we are not now recommending using it in patients with heart failure. We are
Excellent.
waiting for the recommendation from the guidelines and approval from Saudi FDA whether to use it with heart failure or not.
Excellent. So there's a question here, Dr. Hamid, saying, is it better to start with 20 milligrams of finerenone or 10 and then 20? But you mentioned it in your presentation, but if you just can highlight it once again, it would be clear for all of us.
The standard dose is 20 milligram. So we are aimed to, by the end of the day, keep most of the patient on 20 milligram. That's why even the real world evidence, I told you that the change from 10 to 20 was minimal. And we need to encourage our physician to escalate the dose up once the potassium is not increased. We'll start only 10 if the GFR is less than 60. And after 4 weeks, if the potassium is normal, directly, even the GFR is still less than 60, we will escalate the dose to 20. So by the end of the day, most of the patients should be on 20, not 10. 10 is the starting dose for few of the patient with GFR less than 60 for only 4 weeks. After that, most of your patient would be on 20 milligram. This is the standard of care,
Yes.
20 milligram.
Excellent, clear. There is a question from Dr. Ahmed Al-Hayt. He said, earliest stage of diabetic kidney disease is hyperfiltration, where patient have higher than normal EGFR. Do we have any active role here? This is the early stage.
No, the recommendation for using finerenone is confirmed chronic kidney disease by GFR less than 90 and urinary albumin creatinine ratio more than 30. And the transient hyperfiltration is short-lived, and soon with hyperglycemia and increased glomerular filtration, glomerular pressure, interglomerular pressure, the deterioration will occur. So once there is GFR less than 90 and albumin creatinine ratio more than 30, this is a time where you need to start finerenone after a maximum tolerated RAS blocker.
Yes. Just to put the things in its perspective, Dr. Hamid, from the real world practice, what stages of chronic kidney disease the family physicians and the primary care can manage successfully? You mentioned it, in the first 3 stages.
In the heat map, yes.
Yes.
It's mentioned in the heat map. So G3B and A2, this for sure is our patient.
Yes. Mm-hmm.
Except if there is rapid deterioration of the GFR reduction or increase in the albumin creatinine ratio, at that time we need to refer. Then this will be co-managed between us and the nephrologist.
Yes. Unfortunately, there is some of the doctors in primary care still using urine analysis to identify the protein, while they are not using the urinary albumin
Not sensitive at
creatinine.
all, and it will be measured after in the late stages of the kidney chronic kidney disease, and it will be too late for such patient to benefit and to get the benefit of the finerenone. Please, urinary albumin creatinine ratio spot, not 24 hours, just urine sample, better in the morning, but any time, and urinary albumin creatinine, not proteinuria. We are not measuring proteinuria. It is a very,
Yes.
very late stage, as you
Yes.
said, Dr. Ashraf. Thank
Yes.
you.
Yeah. Thank you. I think there is a question. Um, um, okay, you mentioned about the hyperkalemia. This was a question, the risk of hyperkalemia and the reduction the EGFR when starting ferrinols. Yes, we have said this. And the question, Dr. Abdulhamid, if you diagnose a patient's newly naive patient with diabetes, do you screen for USCR and EGFR immediately, and how frequently you will be repeating the test?
Thank you. The standard of care for any patient with type 2 diabetes, we need to screen him from the day of diagnosis
Mhm.
for many things, including the kidney, the nephropathy. So from day one, we need to screen for serum creatinine, GFR, and urinary albumin creatinine ratio. And this should be followed according to the condition of the patient, the control of the hyperglycemia, the level of GFR and the urinary albumin creatinine ratio. You may need minimally annually. You may need to repeat it after 6 months, but it is the standard of care from day one of diagnosis and annually. And if any abnormality, you need to monitor the patient more frequently.
Absolutely. You mentioned, Dr. Al-Hamid, regarding the cases which is usually associated with elevated UACR, like pregnancies and others. Do we put them in our considerations when we evaluate the patient for the first time?
Yes, we need to consider these possibilities, severe hyperglycemia, severe hypertension, or fever, or this, to repeat it later on. Don't consider this result,
Mhm.
the albuminuria, and you need to repeat it when the patient is under control, and take this result, not the one with the factors that may elevate falsely the albuminuria.
Yes, absolutely. It has been not long time ago when we used to treat patients in silos, diabetic patients, heart patients, and renal patients, you know. So now we are talking about the cardiorenal metabolic syndrome. So I think the cardiorenal metabolic system are interconnected together. One will lead to the other. So if you just can highlight this kind of connectivities and how we can approach this kind of holistic visualizations of the problem as a primary care physician.
Thank you. As I said, the American Heart Association said it is cardiovascular kidney metabolic syndrome, and the preventive calculator is including GFR, body mass index, A1C. So we include everything in looking for the risk of our patient. We care about what the possibility to develop problems. And as it is mentioned, the mortality from cardiovascular is the leading cause of death among patients with diabetes and among patients with chronic kidney disease. So including cardiovascular with the kidney and the metabolic is highly appreciated. And one paper review article I presented at the beginning of my presentation talking said the kidney alone and the heart alone are bad, but together they are very bad. So
Yes.
the presence of chronic kidney disease and heart failure or hypertension or MI, it means the patient at very high risk, and we need to be very aggressive in managing all the components you mentioned. The hypertension, the dyslipidemia, the diabetes, the obesity, everything. Yes.
Yes. There's a questions, but the doctor did not mention his name. What should we do if a patient was started on 10 milligrams Ferinone, and after 1 month we found increase in the potassium and decrease in GFR? Should we wait and repeat again? I think you have answered this question, Dr. Hamid.
I need to know the level.
Yes.
Reduce or increase
The GFR.
Anything for me. I need what is the level of potassium after 4 weeks and what is the level of GFR after 4 weeks. Then I can answer. I mentioned it. If it is 4.8, you escalate the dose to 20. If from 4.8 to 5, keep the dose as it is. If more than 5.5, you stop for 4 weeks and re-evaluate later on.
Okay, I think this is all what we have. There were some comments. Some of the audience, they appreciated your talk, Dr. Abdul Hamid, and they are value the content of your presentation that was really enlightening from the practical point of view. So I think we will, with this, we will close, and yeah, there is no more questions. So, ladies and gentlemen, I would like to thank you for your attendance, and I would like just to recap what has been said by Dr. Abdul Hamid. Chronic kidney disease is a common problem that encountered the primary care physician in association with diabetes as a complication. So our role is to identify those people at risk and to early diagnose them using the EGFR and UASCR. And then the heat map should be available to each one of us, to identify exactly what are the stage and whom to treat and when to refer these patients, and using the Ferinones. In fact, as this was highlighted elegantly by Dr. Abdul Hamid, it decreased the cardiovascular mortality and morbidity by 14%, decreased the hospitalization for heart failure by 22%, and decreased the progressions of chronic kidney disease. And this is a real value that we can obtain by using the Ferinones. Of course, you have to monitor the potassium levels, and it has been shown by all the studies that it is very efficacious medication, safe medication with a good tolerability. So I think now with this all information that we have gathered today and putting these recommendation and guidelines into real world practice, I think from tomorrow onward, inshallah, we'll be able to identify our patients with diabetes and chronic kidney disease and starting the Ferinones along with other medication which has been recommended by the kidney group. So with this, ladies and gentlemen, I would like to thank you, and on your behalf, I would like to thank Dr. Abdul Hamid Hassan for the senior consultant for medicine from the International Medical Center. I was with you, the moderator, Dr. Ashraf Amir. I'm a consultant for medicine from International Medical Center as well. And I would like to thank Bayer Company for giving us this wonderful opportunity. And thanks to the Saudi Society for Family and Community Medicine. And thanks for ملتقى الخبرات لتنظيم المعارض والمؤتمرات for the wonderful organization of this event. Looking forward to see you again and again, ladies and gentlemen, in some other new scientific event. Till then, I would like to say goodbye. Wassalamu alaikum wa rahmatullahi wa barakatuh. يعطيك العافية دكتور حميد.
شكرا جزيلا دكتور أشرف.